Mr. Doherty, can you hear me okay?
Yes, sir. It's great to see you.
Yeah, likewise. Thanks for having me down a couple weeks ago. It's good to see you guys down there.
Chair Foster, it was an absolute honor and pleasure and a great learning experience for Rhonda and I. So thank you, and for our community. Thank you for taking the time to be here. And I'm glad you got through all the lightning and everything to be here.
Yeah, no, it's an enjoyable community meeting. I really enjoyed that one a lot.
Oh, so did we. And your presence was incredibly, it meant a lot to this community. I've heard a lot of great things about it. So thank you.
Yeah, it was a good, I enjoyed it a lot. Do you have everyone you need on your end?
I believe so. I know my board chair is actually in the office next to me, and she's going to kick us off. I believe I have my chief nursing officer, chief medical officer, and chief financial officer with me.
Okay, and I see Rhonda. Okay, so what I'll do is I'll go on the record here in a minute, and then our attorney will swear you in, and then you'll just have to state your name for the record and for the court reporter, Michelle, so she can take it down. And then after that, we'll turn it over to you, Rhonda and Chris, and you guys can take it away with your presentation.
Fantastic. Thank you. Perfect.
Okay. All right. Michelle, you all set?
All set, ready.
Okay, we can go back on the record.
We are now back on the record. It's 2:31 p.m.
Thank you. We'll resume the Care Board's hearing of August 14th. Last today, but not least, is Brattleboro Memorial Hospital's presentation of their budget. I'll have Mr. Henksler swear in the witnesses, and we'll turn over to Brattleboro after that.
Hey, good afternoon, everybody. For anybody who is planning to present or provide answers to board questions from Brattleboro, I'm going to read the oath to be administered to witnesses. And what I'll ask you to do is individually, after I read it, state your name, raise your right hand, and say, "I do." And then that way we have everything on the record. So do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Say your name.
Oh, Rhonda Calhoun, I do.
Chris Darty, I do.
Kathleen McGraw, I do.
Jackie Ethier, I do.
Laura Bruno, I do.
I believe that should be it, Chair Foster.
Great, you're all sworn in, and I'll go ahead and turn it to you to begin your presentation.
Thank you.
Should I do introductions first?
Yes, I think Laura's going to bring up the slide.
All right.
Is the board bringing up the slides? Or should I share?
I think if you're able to share, that would be great.
Can Kristen unshare? Thank you. Okay.
Oh, really? That's good.
Can everyone see that?
We can. Perfect. Thank you.
Okay.
Good afternoon, Green Mountain Care Board members. I would like to introduce you to our lead team. We have with us Christopher Doherty, who's our President and Chief Executive Officer. Dr. Kathleen McGraw, she's our Chief Medical Officer. Laura Bruno, she's our Chief Financial Officer. And Jackie Ethier, our Chief Nursing Officer. And they will be doing the presentation today, but I have a few words that I would just like to kick off the meeting with. And again, good afternoon. First off, I'd like to thank Chair Foster and board member Dr. Merman for taking the time to meet with our CEO and me prior to our community meeting presented by Dr. Hammery. It was educational for me that you shed light on the challenges facing not only all of our hospitals, but our state as well. Challenges we are all too familiar with. The time to take action hopefully has not slipped away, but this is not time for inaction. It is a time for improvement, for change, and transformation. That is why our proposed budget, which has been thoroughly reviewed by our community board, has been strategically and thoughtfully developed with our unique community in mind. Our team is committed to sustaining the health of our community within our means. We are dedicated to the provision of services and quality health care for all of our patients. Our budget stresses these goals, is responsive to community needs, and is financially sound and responsible. I express my appreciation to the entire BMH team for their willingness to go the extra mile and to present a well-balanced, cohesive budget to you today. Thank you.
Well, I would just like to echo Rhonda's gratitude to Chair Foster, Dr. Merman, and all the Green Mountain Care Board members, and also especially to the Green Mountain Board staff. We really appreciate the work that you do each and every day to make this a better place for all Vermonters and to help us navigate the treacherous waters of healthcare. 2024 is a great year. It actually marks the 120th anniversary of BMH being a community hospital. It's pretty remarkable in this day and age that a small, independent rural hospital can survive for 120 years and hopefully 120 more. When we reflect on our very rich history, we realize that BMH was started all because of love. It started because Thomas Thompson fell in love with Elizabeth Rawls on his visits as he would travel from Massachusetts, where he was a very successful businessman, through Brattleboro into Vermont. He fell in love with Elizabeth and eventually they married. And the two of them, because of their generosity and the love for this community, decided that they would make sure that a charitable foundation was developed to support charitable efforts here in Brattleboro. It was easy to see that this community needed and desired a high quality community hospital here in Brattleboro. So they created Brattleboro Memorial Hospital, and that's how we got started. Now, as Rhonda mentioned, we had a great education from Chair Foster, Dr. Merman, Dr. Hammery about the challenges that we face. I think it's important to note that, again, through our very rich history of 120 years, BMH has sustained and actually thrived through many challenges, including world wars. They've survived through floods, epidemics, and multiple changes in healthcare payment reform. And the reason why BMH has been able to continue to sustain through all of this through 120 years is because of persistent, even relentless efforts to make sure that this treasured community hospital stays in Brattleboro. So the lots have changed in these 120 years. A couple of things have never changed. We still have this great love for the community, and it's what propels us into action each and every day here at Brattleboro Memorial Hospital. And we also still have the same sole purpose for existence, and that is to serve this community. That has not changed. We're still very persistent and even relentless in our efforts to keep this community hospital and this community treasure here in Brattleboro. So fast forward to today, 2024, 120 years later, and Laura, you can go to the next slide, please. And here's what we are. We are still an independent, nonprofit community hospital. Just a reminder to everybody, we are the only Medicare-dependent hospital in Vermont. We also do get a low volume adjustment for from the Medicare Dependent Hospital Program. What we are today is that our Medicare spend per beneficiary is less than the national average because we have become a very efficient, high quality organization. We're a large employer for this community, which is very important to hopefully stimulating economic growth in our community. And we've become much more than a hospital, but much more like an integrated delivery system where we also have a community, a medical group, we have community affiliations and ties that makes us much more of an integrated delivery system. Laura, can we move the slide ahead actually now, please?
Gina has the slides. Right now, we're just having this minor technical difficulty.
Okay. Well, thanks. All right. Well, you can kind of see it in the small corner there, but we have an enterprise-wide balance scorecard because we have 7 key strategic priorities that we seek to fulfill each and every day. And we strive to help utilize this to monitor how well we're doing towards fulfilling our mission as an organization. We report this to our board once a month, and these results fuel our continuous improvement culture here at Brattleboro Memorial Hospital. I am actually delighted to introduce Dr. Kat McGraw, our Chief Medical Officer, and she's going to talk about continuous improvement here at Brattleboro Memorial Hospital.
Dr. McGraw, if you would just take a quick break and let us get this squared away. Apologies for the technical difficulty.
It's totally on my.
Jump in if you can. You're sworn in. Here we go. Okay. You can go one more ahead to Dr. McGraw's slide, please, Dana. Thank you.
Great.
Perfect.
Excellent. Thank you. All right. So we can do it with slides. So I'm going to talk a little bit about BMH's investment in quality and patient safety and our ongoing work on continuous improvement in that. Approximately 3 years ago, we started working with the ACHE Blueprint for a Culture of Safety, and this involved bringing our board and community members and staff together to really look at how we do things and do really an inventory of our practices in the ways in which we can shift our focus so that we had some increase in a real culture of safety. And that has been tremendous. And I think you can feel it here at the hospital in a way that's really encouraging and exciting. The number of quality improvement projects that are going on around the organization is just tremendous. And each fall we're holding a quality showcase where there are many projects that are proudly displayed, and most of our leadership has been Yellow Belt certified for Lean Six Sigma, and there's just really a big shift here. And the nice thing about that is that we're starting to see some outcomes for that. Outside of our organization, we are getting some recognition, which is nice. The Leapfrog grading, which I'm sure you're familiar with, has consistently been giving us a B grade on safety now. Our HCAP scores have continued to improve year over year, and we've also consistently been getting a 4-star rating for that. Our CMS stars are also 4 stars on quality, which is a delight as well. Recently, the Lown Institute, who I know you all are familiar with, or at least some of you are, because I've seen that come up in some of the previous discussions, recognized us twice. Once, we were cited as the most socially responsible acute care hospital in Vermont. Really, that's the social responsibility and the health equity are based on about 50 different metrics, for which most of them we received A's and B scores. So that is pretty exciting. And also with respect to community benefit, in April, we were noted to have the best fair share score in Vermont, and really a good one relative to the rest of the country as well. And that particular score is meant to measure our community investments and free care. Our work around quality of care delivery and patient safety is in line with the Lown Institute's goal of doing as much as possible for the patient and as little as possible to the patient as we work to achieve health equity and eliminate healthcare disparities. Next slide, please. There we go. Another way in which we've seen some of this outcome is around the value-based purchasing program with CMS. As I'm sure you're aware, they withhold 1% of our DRG base payment and then add that back based on certain quality metrics. Those metrics are largely focused on orthopedic outcomes and mortality rates on some specific common and significant disease states. And as you can see here on that curve, BMH is the green line, and we are ahead of the curve, which I'm really happy to report. And this means that they have given us not just our 1% back again for the quality metrics, but also a little bit of a boost at that 0.16 added to it, really based on our quality care metrics. And I will just add that earlier this week, I heard that for this next year, we've had continued improvement, and we will see our bonus be 1.38, which is even a little bit better and reflective of the care that we've been delivering. Next slide. And then thirdly, I want to just point to a really thrilling recognition, which is the CMS, our CMS Quality Improvement Organization is IPRO, and they chose to nominate us for a New England award for quality improvement, and this is the poster that they actually put together for part of that that nomination process. That it was around our reduction in readmissions project around heart failure and COPD. And it is a project that is incredibly interdisciplinary across the full continuum of care. You can see the photo in tiny little pictures down below, but those folks represent, you know, pharmacy, inpatient, outpatient, and the full range of touch points for patients. And we made changes based on data, and input from patients and staff. And we have really seen decreases in our readmissions for both heart failure and COPD, and continue to see that. And I'm happy to say that we actually won the award that we were nominated for. So that was a real thrill. And I think the thrill about it is not so much the recognition per se, although it's nice and it's great and really essential for the staff and for the work that we do, but it really just represents that we are seeing outcomes in quality of care, outcomes in readmission reductions in ways that are palpable and meaningful for the work and the investment that we've put into it. And now I'll turn it over to Laura.
Actually,
Chris.
I'm going to do this one, but thanks, Dr. McGraw. Thanks for talking about continuous improvement. And that continuous improvement is the foundation for all we do here. We try and get 1% better each and every day. And that'll be very thematic throughout the presentation today. Just a few other things we'd like to highlight is that we are still in the recovery mode from the awful Change Healthcare cyber attack and the financial impacts it had. We use Change Healthcare, which is owned by United. We use them as our claim scrubber and claims clearinghouse. And so it was down for over a month because of a cyber attack with some ransomware challenges that really created a major problem throughout the country, but hit us very hard because we weren't able to get claims out the door, nor were we able to post payments for almost 2 months. Thanks to Laura Bruno, our Chief Financial Officer's great work, we have been able to manage our way through, but there's still a lot of catch up in terms of accounts receivable coming in that needs to continue to happen as we have survived that terrible attack. We are looking at some targeted growth in very specific outpatient areas. And this was because, as Dr. Hammery pointed out so well, Vermont is very much an aging state. We happen to sit in the county that is the oldest county in the state of Vermont, Windham County, and we're seeing the impact of that on the care that we deliver. A lot more chronic illnesses, a lot more cardiology, a lot more cancer, a lot more podiatry. So we're trying to beef up some of those services, and some of the growth that Laura will talk about when she presents our budget will be in these outpatient areas that we're looking to grow, and especially in our Medicare insured patient base. I think it's important for us to talk about some of the big things we're doing for cost saving efforts. There's a million things we're doing on a daily basis to save costs. That is the one thing that no matter how you look at healthcare, costs need to be removed from healthcare, and we're looking at ways to do it. We're looking at some big things, and two of them are listed here. One of them, I just noticed a typo, and boy, am I going to get a hard time from Joe Wooden and Peter Wright. We are transitioning to the NECHN, which you've heard about from both Peter and Joe, the New England Collaborative Health Network. And yes, it's for group purchasing, but more importantly, I think it's also for shared service opportunities. We're continuing to share services with the Brattleboro Retreat, which is 1.6 miles away from us, as it relates to information systems. And we're getting some great opportunities through this collaborative. And I know Joe and Peter have talked about that. We're also very much partnering with a very solid federally qualified health center close by to bring a federally qualified health center to Brattleboro. Windham County is the only county in the state of Vermont without a federally qualified health center. And there are great advantages for the community for us partnering with a federally qualified health center, and we're in the midst of doing that. So these are some of the big things that from a theme perspective you'll hear. Gina, you can go to the next slide, please. Just a couple of highlights of some other things that we're doing. Innovation is such a vitally important part of what we need to be doing for transformation. We're very proud to say that we've launched a mobile integrated health network with Rescue Inc. as a community partner. They are an EMS service located about a block and a half from us. And in this, we actually have community paramedics going out to the homes of individuals to try and keep people in their homes, keep them out of coming to the emergency department if it's avoidable, and keep them out of being admitted to the hospital if it's avoidable. Now, we started with a very small, finite subset, and that was really our joint replacement surgery patients, where the community paramedics go into the homes prior to surgery to make sure that it's safe for the patient to come back, hopefully the same day that they have the surgery, to their home. Then they visit them the day of surgery, making sure that their pain is being managed, and keep visiting them on a regular basis to try and make sure there's no surgical site infections, that their mobility is good, and that they're taking their pain medication in a responsible way. We've seen some great outcomes from that. And what we're really excited to do is to start really working on the areas where mobile integrated health can reduce healthcare costs substantially, and that's with the chronically ill. So we're starting with COPD, and then we will migrate into CHF. We've even talked to Blue Cross Blue Shield to see if there are certain pain points in terms of diagnosis that this might be something that we can partner with them on to try and bring down costs for everyone. We're experimenting with artificial intelligence. We're very excited about how it may impact us in terms of efficiency into the future. We have a few different projects that we're looking at this point in time. We've started to do some clinical documentation work with artificial intelligence, with the goal of having our providers be more efficient in their documentation so that they can spend time on caring for patients. We've also started to explore and look at the potential of artificial intelligence in claims processing, and actually working with denials management as well. And then finally, we're looking at implementing a digital front door where artificial intelligence would help us in managing inboxes for clinicians, messages that come in for clinicians, and making that process much more efficient than it's been. Dr. McGraw mentioned that we've been infusing Lean and Six Sigma into our leadership team. I think all of our directors have been trained and are now yellow belts for Lean Six Sigma, and that's becoming a big part of our culture here at BMH. I think you've probably heard an awful lot about the New England Collaborative Health Network. We're very excited about the potentials. I kind of think the potential is pretty much only limited by imagination, and there's a lot that can be done to reduce the cost of healthcare, not just in hospitals, but also with our community partners. And we're actively looking at community partners who we can bring into this collaborative. We're actively preparing for the AHEAD model, and we've talked about partnering with a federally qualified health center, which will help us bring down costs because we will be able to share those costs over to the federally qualified health center, especially for primary care here. You can go to the next slide, and I believe now I'm going to introduce Laura Bruno, our Chief Financial Officer.
Thank you, Chris. Okay, so I'm going to walk us through our budget proposal for FY25. Starting off with just a look at the fiscal year-to-date May 2024 performance. So despite, as Chris mentioned, facing some considerable headwinds with the cyber attack from Change Healthcare this fiscal year, our performance, our financial performance has actually been relatively strong. When we look at the year-to-date May 2024 period, revenues came in favorably, driven by the medical group, radiology, and pharmacy primarily, with offsets in operating room and emergency room volumes. Wages are also favorable to budget by 2.1%. During FY24, we launched a smart hiring committee to put form and discipline around spend on new hires, both in clinical and administrative roles. We have put a few tactics in place as part of that process, eliminating repeat postings that carry over from year to year, requiring business justification for any unbudgeted hires, and setting financial thresholds to justify even budgeted hiring. We're also in the process of launching a position control system. We experienced contract labor overspend of $1.7 million, which is partly related to RN shortage, but also we're starting to feel a shortage in some of the allied health roles, technical roles in radiology and lab. Contracted services were favorable due to mainly to the impact of Change Healthcare cyber attack, which in effect put a lot of our projects on hold because of the cash constriction. In total, year-to-date May, we're reporting a loss of $115,000. For our FY24 full year projection, we're forecasting favorability on net operating revenue of $2.8 million or 2.4% versus budget. We expect to see wage favorability continue and approximate $1.1 million or 2.2% versus budget due to the disciplines that I mentioned on the previous page. We will overspend on contract labor by about $2.5 million due to lack of availability, as I mentioned, of technical hires for radiology and lab roles. We had strategically set the contract labor budget low in FY24. Contracted services are favorable due to spend avoidance in this year. Worth noting that healthcare provider tax will exceed budget by $650,000 this year. And for the full year, we're projecting a loss of $172,000. So this is kind of a truncated balance sheet for FY24. mid-year. As Chris mentioned, we were impacted by the cyber attack on Change Healthcare, which is the parent company of our claims processor Assurance. This nationwide event dramatically affected our balance sheet dynamics, including cash, AR, and AP. We are still very much recovering from the outage, and the balance sheet reflects this recovery period. You can see that just between April and May of 2024, we experienced a pretty dramatic decrease in both AR and AP. We have been working hard to clear out the claims that were backlogged in our EHR as quickly as possible, thanks to a concerted effort from our revenue cycle team. Our AR levels are slowly declining as a result. The lack of cash flow during the outage made it nearly impossible for us to pay our vendors, and we fell behind on AP. We received short-term emergency funding from OneCare Vermont, Medicare, and Medicaid, which allowed us to sustain operations at that challenging time. BMH made commitments during the outage to continue to pay our employees and to sustain all patient care despite these financial challenges, and I'm proud to say that we adhered to those commitments. Our balance sheet fundamentals continue to be strong, and we are seeing working capital improve each month as we gain some distance from the cyber attack. So the budget comparison, the second column highlighted in yellow on this slide is our budget P&L for FY25. We're projecting $302 million in revenues, which is a 7.8% increase over FY24's budget. We're planning, as Chris mentioned, for growth in cardiology, podiatry, and to a kind of lesser extent ortho, and as an ancillary to cardiology, podiatry, and ortho, and MRI and echocardiography. We are planning for our inpatient services to remain relatively consistent in volume year on year. Our NPR fixed prospective payment increase is set at 2.5%. We're projecting 4.8% growth in wages, despite holding our headcount virtually flat. The year-on-year dollar growth in wages reflects our collective bargaining agreement increases, as well as our need to compete in a tough labor market with employers from Massachusetts and New Hampshire. Growth and benefits spend will roughly align with the wages, the wage growth that we're seeing. We again budgeted $1 million for contract labor in hopes to continue to decrease our reliance on travelers. Med-surg supplies and drugs lines are up, primarily due to the fact that we had under budgeted for those areas in FY24, but also, obviously we're experiencing inflationary impact in those lines in particular. Other supplies and expenses are increasing by 13.8%, mainly due to fuel costs, which increased by 8.2%. Due to the expiration of a fixed contract that we had on fuel. Depreciation and amortization reflects the non-cash impact of CIP projects, plus the projects that we are planning to undertake in capital this year. Our budget for the provider tax is up 10.5% or $600,000 versus last year. And overall, we are presenting a small positive margin of $551,000 or 0.46%. Chris, would you like to address the next slide?
Thanks, Laura. Yes, Laura's about to go through our rate request with you all, and I thought I'd just give a little bit of a backdrop before she does that. There's other challenges. Dr. Hamery did such a nice job, and the whole Oliver Wyman team, of pointing out all the challenges that we all face. There were some things that some are specific to us from the federal government perspective, as well as some things that we would love to work on with the state. So from the federal government perspective, we are a Medicare dependent hospital with a low volume adjustment, and that accounts for about $3 million to our bottom line each year. Unfortunately, that's always at risk because that has to be approved by the federal government. It actually takes an act of Congress to keep the Medicare dependent hospital low volume adjustment program in place. We're assured that it's in place through December 31st of 2024, but somehow Congress has to agree before December 31st, 2024 to put it into a longer period of time. There is a US Senate bill that would make this permanent, and we're certainly hopeful for that. As a Medicare dependent hospital, I think it's important for you all to hear as you look at our rate requests that we do not get an increase from Medicare OPPS payments. I believe we're the only hospital in the state of Vermont that does not benefit from any increase in OPPS, and that is because of our Medicare dependent hospital status. You may know that Medicare set their IPPS rates at a 2.9% increase for next year, but they lowered the physician payment by, I believe, or are going to lower the physician payment by about 1.7%. I think from the state perspective, Laura's mentioned a couple of times the provider tax, and that it's about $6.7 million that we pay in provider tax, and we have no problem paying provider tax. I just would point out that that rate is at 6%, which is the max allowed by the federal government. And in most states, it's an average of about 3 to 4%. In most states, there is a relationship between the disproportionate share payment and your provider tax. For us, we get about 10% of our provider tax back in disproportionate share. Laura, please correct me if I'm wrong, but next year, I believe we're actually going to receive $40,000 less in disproportionate share.
Correct. So that'll be less than 10% of our provider tax.
Even though our provider tax is going up over $500,000. In most states, the disproportionate share relationship to provider tax is closer to 50%. Actually, in neighboring New Hampshire, I believe it's 71%. So some things to hopefully consider in a collaborative way with the state as we look at things. I think the only other thing I'd like to point out is that, also factored into this, our rate increase request is that we found out kind of in the middle of the budget process that Medicaid is not going to offer any rate increase for fiscal year 25, which again creates a challenge for our expenses, inflation, everything are going up substantially. We're doing everything we can to reduce costs, but there's very little in terms of levers we can pull to increase revenue. And I'll turn it back over to Laura, I believe.
Thank you. So this slide is a review of our charge request. Overall, on a blended basis, we're presenting a charge increase of 2.7%. This breaks out to 1.5% on professional fees and supplies and 3.2% on the hospital. Broken out by payer, we are reflecting the Medicare IPPS rate increase of 2.9%, a 0% increase from Medicaid, and a commercial rate request of 4.7%. Our NPR with fixed prospective payment will represent a 2.5% increase over FY24, and we're planning for a small operating margin of $551,000. In terms of volumes, budget to budget, we're projecting consistent, relatively flat performance in our core inpatient units, such as the birthing center, progressive care unit, Med-Surg 2, and inpatient surgery. We are planning for modest growth in a couple of areas to support our aging population, as I mentioned earlier, so cardiology, podiatry, imaging, and orthopedics. So this next page is just a breakout of the key buckets of inflation that we're anticipating in FY25. We expect wages to increase by approximately 4.8% or 2.5 million. Drugs are inflated largely because of expensive infusions for cancer treatment, for which we are not typically fully reimbursed. Additionally, as I mentioned earlier, we I believe under budgeted on this line for FY24. The healthcare provider tax is, as we've mentioned, is mandated at 6% of NPR. So as we grow, it increases. This year, it will increase by 10.5% or $600,000. Fuel, we discussed on a previous slide. In total, we anticipate our inflationary impact to approximate $5.5 million. Capital. We met as a capital committee internally at BMH to review all requests and either delay or defer any unnecessary requests, capital requests to FY26 and beyond. The capital budget is really a result of that process of whittling down purchases to what was absolutely necessary for patient care, diagnostic services, and the upkeep of our physical plant. The most significant single capital investment in the plan is a replacement MRI. We anticipate the new MRI to be installed hopefully around January of 2025, if that all goes according to plan. A few other examples of planned capital are a nuclear medicine camera, new endoscopy platform and scopes, IT infrastructure equipment, new stretchers and patient beds where needed, and lab equipment. We're also prioritizing the safety and security of our physical plant and are making investments in that area. We're conducting an end-to-end revenue cycle engagement with Barry Dunn, which is a consulting partner of ours. As a sub-project within that engagement, we will be centralizing our scheduling and registration processes in order to improve patient access to our services. By centralizing scheduling and registration, we believe we will gain efficiencies that allow us to shorten wait times for visits and simplify communications between patients and clinicians. Another big area of focus in our revenue cycle engagement is growing patient participation in our financial assistance program. We are increasing our marketing of the program at our facility and in Windham County and aim to improve our ratio of charity care to bad debt over time. We're publicizing the benefits and eligibility requirements for Act 119 and will hope to gain traction with the program through these efforts. Pricing transparency is another focal point in this project. We want our patients to understand their bills from BMH and be able to accurately predict the cost of their visit to improve affordability overall. So the next two slides are risks and opportunities within the budget. So I'll just run through these quickly. Timing of the establishment of an FQHC in Windham County is unknown at this point, though we would like to see a conversion around the beginning of calendar 2025, but there is still a question around that. We are facing an unpredictable labor market, specifically in technical roles in radiology and lab, and we do see some challenges there. There is also some degree of unknown around the amount of volume we'll see corresponding to bringing on additional providers in cardiology and podiatry. Windham County's population is aging and faces a greater likelihood of chronic illness, which does present a greater financial risk to BMH. And generally, the growth of Medicare Advantage participation is a risk to BMH. As Chris mentioned earlier, Medicare-dependent hospital and low-volume adjustment designations are cyclically at risk and are set to expire on December 31st of 2024. So we'll be looking out at that horizon. Continued difficulties of getting patients to a higher or lower level of inpatient care is a risk for us. And then, as always, recruiting and retaining high quality providers. As for opportunities, the FQHC is on both lists, risk and opportunity. The establishment of an FQHC in Windham County will improve access to care and services in our community, and it will also offer cost savings to BMH. Our transition to a new group purchasing organization will offer savings due to greater economies of scale in our purchasing. We are utilizing AI for scribe services in our medical group, which we think will improve provider retention by simplifying the process around dictation. The revenue cycle project with Barry Dunn will drive efficiencies and increase cash collections at BMH, allowing us to invest in critical path items. And the expansion of mobile integrated health and community paramedics will reduce ED visits and avoidable readmissions. So at this point, I'm going to hand it over to Jackie Ethier, who is our Chief Nursing Officer.
Thank you, Laura. Nice to see everyone. I'm going to talk a little bit more about our workforce realities that we're facing. We're going to look at contract labor spend. I know this is small, but this is fiscal year over year spend since fiscal year 19. You can see the lighter blue is nursing specific. The darker blue are those non-nursing roles. And in fiscal year 22, we experienced the post-COVID impacts to our nursing workforce that many organizations saw requiring significant increase in those traveler resources. Luckily, since fiscal year 23, we're continuing to see a decrease in those contract labor expenses for nursing, which we attribute to our focus on redesign of our new graduate nurse residency, as well as our ongoing recruitment and retention efforts for permanent staff. As Laura had mentioned, we are experiencing an increase in allied health workforce needs. So specifically, as she has said, radiology, laboratory, as well as respiratory therapy, which is a critical resource for us here, being a small community hospital, only having one respiratory therapist around the clock to meet all of our patient care needs. So we're seeing those costs drive up with really lack of regional pipelines to hire permanent staff into those roles. And so we have an ongoing opportunity there regionally to continue to develop those pipelines. Next slide, Laura. Thank you. So workforce challenges or opportunities, as Chris also mentioned earlier, the Oliver Wyman report really exemplified for all of us the workforce realities that are facing us in Vermont. So the aging population is projected to continue with a corresponding decline in our workforce. So we're going to continue to have to face those challenges. As I already mentioned, the lack of pipelines, so that allied health, lack of schooling and programs in our region is a reality we're facing right now, and we really need to lean into strategies to address that moving forward. It's important to note regarding our capacity that capacity is not just about physical space, that we must have the human and equipment resources to provide the complex care that we need, which requires ongoing exploration and investment into the future. As previously mentioned, too, we continue to struggle with regional and seasonal surges where we lack the ability to transfer either to a lower or higher level of care, which creates internal surge for us and challenges that we have to address on a routine basis. Next slide, Laura. So workforce solutions, compensation obviously always comes up, and you can see what we've projected for future spend on compensation. We recently implemented a new structure, really working towards consistency and equity for all of us. We continue to partner with all of these organizations across the tri-state area, really working to in addition to working with the Vermont Talent Pipeline Advisory Group, we are collaborating and strategizing with all of these individuals into the future to really grow these resources as we move forward. It's important to note about culture that the evidence tells us that most employees leave roles primarily due to their immediate work environment. Therefore, we're deeply committed to supporting and developing our culture with the strategies listed here. So I think I'm handing it back to Laura. Is that correct?
That's correct. Yes. Thank you, Jackie. So to summarize our FY25 budget proposal, we are presenting a 2.5% increase in NPR, a blended charge increase of 2.7%, and a bottom line margin of 0.46%. We believe this is a responsible budget request. And there are three key focal points as we look towards FY25. Rebuilding and strengthening our operations with an eye towards sustainability, putting community engagement at the forefront of all that we do, and becoming a population health focused system. Chris?
Well, again, we want to thank you all for listening to our budget presentation. We're excited to entertain questions. Before we end, we would also like to thank you for, again, the very important work that you do each and every day for the state of Vermont. It's commendable, it's admirable, and it's very vital to the success of this state and the health of our beloved communities. I think as we look, this budget that we're presenting you today is the first year of our next 120 years. We hope that you'll approve this budget. We're happy to discuss it with you in full, but we also believe that what's going to help us sustain for the next 120 years is a lot of what has helped us get to where we are today. And that's that everything will be done out of love for this community, and to also complete our noble mission of serving this community. We believe that the attributes of persistence, innovation, and resilience are going to be vitally important to our future. So just adding to what Voltaire has said over 120 years ago, that no problem can withstand the assault of persistent thinking. We believe that's true, but far be it from me to add to Voltaire, but I would say not only persistent thinking, persistent collaboration, persistent innovation, and most of all, now is the time for persistent action. So we thank you, Chair Foster and team, and we're ready for questions whenever you're.
Thank you very much. That was really helpful. I'll turn to Board Member Walsh for any questions he may have, and then the others.
Thank you, Chair, and thank you, Chris. It's nice to see you again. I wanted to start off by just commending you and the organization for your Leapfrog, HCAP, and Lown Institute recognition. I know you started in your role about the time that I joined this board, and it's, I believe, in the hard work that you're putting into things. You also described in your narrative some efforts to address the free care to bad debt ratio and the consulting group that you're working with. I was wondering if you could say more about how the consultants are helping in that area.
Yes. So we're looking at putting more resources towards benefits advocate, so kind of a financial counselor role. We have one person doing that role, but I think we need to not only market the program more and sort of flyer within our community and within our practices, but we also need to, put more FTE type resources against that position, so that we can, meet our patients where they are and provide the education they need on the program and what benefits are available to them.
If I might just add to that, Laura, also part of our implementation of a digital front door, which is really a patient portal on steroids, will make that much easier for people to fill out those type of applications, get that information, those that have access to this digital front door. So trying to do that on multiple fronts, because part of our challenge has also been getting people in to actually fill out these applications. So trying to meet them where they are as well is important for us.
Yeah, that makes sense. That's all good to hear. It's a topic that I want to come back to. I want to make sure that I have this right. You're requesting a 4.7% commercial charge increase, and the 2.7 was the blended, if I'm got that correct.
That's correct.
And the NPR growth of 2.5.
Yes.
In the narrative that you submitted, you noted that you planned a 3.4 commercial charge increase, but then received notice that there was no increase from Vermont Medicaid this year, and that necessitated the change. Have you received word from New Hampshire, Massachusetts, New York about their Medicaid rates for the upcoming year?
I have not, Chris, I don't know if you've heard anything from them.
I have not. Dr. Walsh, that's a very good question. I have not. And I think it's something to explore. And I think that is an important point because we do get some patients from Medicaid, from New Hampshire and Massachusetts that are Medicaid. It's small. The reason for the bump in Vermont is that's about 20% of our patient population. And again, the 60% is Medicare. So that was what threw us for a loop. It would have been nice if they had given that information to the Green Mountain Care Board as part of the budget guidance preparation. That I think would have helped us because we were headed down a path that we sort of got a curveball towards the end, sorry to say. But it's a great suggestion. We'll look into both New Hampshire and Massachusetts.
Yeah, I think I started thinking about it because in the narrative, you had mentioned that because of where you're located and serving Vermont, New Hampshire, Massachusetts, New York, that the commercial charge increase you were requesting wouldn't have much of an impact on Vermont ratepayers. So then I was wondering about if there's no change for Vermont Medicare, but there is change from other states, how all that would flesh out. So the questions in my mind are, what proportion of commercial paying patients are from Vermont and the other states? What proportion of your Medicare patients, Vermont, New York, Massachusetts, New Hampshire, and then what proportion of Medicaid patients? That helped me understand why a 3.3% increase in commercial rate from what you had first thought won't substantially affect the population, the patients from Vermont who pay commercially, but a 0% change in Medicaid for Vermont would have a substantial impact on the budget. Right, so just trying to help me understand that and think that all through with you.
We know that about 25% of our commercial volume is from out of state. You know, how it breaks out by Massachusetts versus New Hampshire, I'd have to look into that to get the split.
Yep, I saw that in the narrative, Laura, that 75% commercial from within state. So that type of information would help.
Dr. Walsh,
me understand.
We need to get you that because I think on the Medicaid side, again, we get a very little bit. No state really likes to see the Medicaid go across state lines. So we don't get a lot from New Hampshire and Massachusetts, but I don't have those specific numbers. I will get it. In Medicare, it's actually kind of irrelevant since it's a federal program. It's going to be the same payment no matter where. Plus, they've capped it in terms of what it'll be 2.9% on the IPPS. We will not get any increase on the OPPS, which is what is growing rapidly. And after Laura had started the budget again, Medicare did the same thing. CMS just maybe 2 weeks ago passed that they're going to lower the physician payment by 1.7%, which also factored into that. But we can break that down for you. They're great questions, Dr. Walsh, and we can break that down.
Okay. I want to switch next to a topic that you saw with Bruce when he was there, the RAND 5.0 data. When we look at that, we can compare relative price for your facility to a break-even price that the RAND Corporation calculates. Your total facility price, as they calculated, is 320% of Medicare, and the break-even price is 204. So that gap is 116 points. That gap is considered an assessment of efficiency and productivity. The total facility percentage of 320 is the third highest in the state, and the gap to the break-even is also one of the highest. And so I know you're very committed to your community, but I'm wondering how your community can afford prices that relative to Medicare are the third highest in the state.
So we'll dig into the RAND report and get back to you on that, Dr. Walsh. I can tell you that, again, as pointed out by CMS, our Medicare spend per beneficiary is actually less than the national average. We're at a 0.9 for that, which is a barometer that we use constantly to look at. Again, as we look at cost, we absolutely agree that cost is a challenge that we need to weed out. While we're doing lots of little things, we're also looking at lots of big things. Please also note that in that cost are things like the provider tax increases hit that. That is very abnormal for a state to have such a high, again, provider tax rate. I think that that's important to note. We are a Medicare dependent hospital, which also means that really the majority of our payments do come from Medicare. So it is really where we actually do have the biggest opportunity to create a sustainable future for us.
Yeah, I think that's we had a bunch of presentations a couple of weeks ago about with the aging population, it makes sense strategically to be thinking about managing the organization to Medicare rates, right? The gap between the facility price and the break-even price of 116 points is pretty large. So as you dig into that data and get more familiar with it, you'll be able to look on the website too how you compare to other places in Vermont. But a hospital that we met with last week has a gap of 11 points. So just room for improvement
Very
there
helpful.
in efficiency and productivity.
Very helpful. Thanks.
Sure. Yeah, and I appreciate the back and forth with this, Chris, the dialogue and your openness. I want to take a look at your balance sheet for a moment. Your total assets were stable relatively from 2020 to 25. It was 101 million in 2020, 103 million in 2025. Long-term debt increased from 7.3 million to 14.8 in the same time, with the largest jump occurring in 2022. I'd like to better understand that growth in long-term debt, if you
Yes.
could.
We had a bond issuance that we used to build the Ron Reed Pavilion at BMH. So that's the reason.
Okay.
It was 2.5 million.
Right.
I apologize for interrupting. What was that number? If I can hear it again.
12.5 million.
Thank you.
During that same, 2020 to 2025, if we look at the profit and loss, the variance between the budgeted to actual bad debt amounts notably increased. Right, in 2020, bad debt budget was 3.5, and the actual came in at 2.1. And then in 2021, it was budgeted at 3.4, came in at 2.8. 2022, 3.6, but came in at 4.8. 2023, 3.9, came in at 5.3, 2024, 4.6 to a projected 6. So the variance between what's in your budget and then what is actually happening has grown considerably.
Yes, that's exactly. So this is what I was referring to with the ratio of charity care to bad debt that we're working on improving. This is a project that will take us some time, but what we would like to see is a shift over time so that our free care and our bad debt, I'd like free care to be exceeding bad debt. But we're not quite there yet. We're putting some tactics in place to
Right.
help people learn more about our financial assistance program and how they can qualify, but they have to sign up. During COVID, we saw a big drop off of people signing up because they just didn't want to come in and sign the papers. And then it just has stayed sort of stagnant from there. And so we're putting some energy and effort behind promoting it right now.
Right. I think that it's, I understand the difficulty that you're describing, but it hasn't stayed stagnant, right? The free care or charitable care has decreased substantially in the same period from 2.8 million in 2020 to $615,000 in 2024. So when I'm looking through those documents, those are things that are jumping out at me.
Yep, and that's what I'm saying. People are not signing up for the program; they're just not paying their bill, which is not what we, it's not the ideal solution.
No. I want to return to the narrative for a minute. In the contingency plan section, under the contingency plan, you wrote that any decrease in our proposed rate our proposed rate increase would threaten compliance with our bond covenants. Could you help me understand how that's a contingency
plan? What I was saying is that we are beholden to the bondholders in the bank where we have our bond issuance, and we report to them on a biannual basis on a 12-month rolling performance on our debt service coverage, our days cash on hand, and other metrics. And specifically, the debt service coverage would be impacted if our rate increase were compromised, because it would lower our revenue and threaten the bottom line.
So I understand what would happen, right? I don't have a personal bond covenant, but I have a mortgage, and if I miss a payment or I make a partial payment, I'd no longer be in compliance, and my ability to finance repairs for my 15-year-old Jeep would be compromised, and then I could end up bankrupt, or home could be repossessed, or even the Jeep, right, which would not be good. So I understand what's happening, but the contingency plan section, what we're looking for there is, if we didn't grant the increase, how would you manage?
Are you asking if we would stop services or
that's what some facilities write in there. There are other options, but that is we're looking for is what would happen. How would you deal with that scenario? So let me just just one more question. Let me just flip it around. If we approved the commercial charge increase and the NPR increase, the commercial charge increases above guidance. And so how that would be utilized to address the community needs that you've identified and the community benefits that you're providing, that type of information would also be useful, right? To see what are your priorities, what are your objectives, what are your key performance indicators, to know that the overage that you're requesting is being used to meet community need and provide community benefit.
Fantastic. And I'll address that, Dr. Walsh. So again, the budget is for a margin of $551,000. So every dime of that gets reinvested back into what we do for the community. One of the problems with having such small margins, which also goes back to the need for having margins, is you cannot invest in the future with no margin, bond covenant or not. So artificial intelligence needs to be rampant in healthcare. It's impossible to invest in that without any margin. There's operational costs as well as capital costs that may be needed for that. So we need a small margin to actually prepare for the future, or we will not be here for another 120 years, because the further we get behind, the harder it is ever going to be to get to a sustainable future. So we look at all of this, a minimal margin as a chance to invest in our people so that we can retain them, and also to invest in technology so that we can start to prepare for the future, so that we will have the workforce of the future that's needed to provide the services we need. But we'd be happy to list out our key strategic priorities as well as those service lines that we seek to continue because of community needs based on our community needs assessment.
I appreciate the thoughtful response. And I want to end before I send it back to Chair Foster. Just, I listened and heard and recognized the recognition you're receiving from Leapfrog and Lown. Congratulations on those. And I think that focus on community and quality and reliability and safety is spot on. And please keep going. And I hope the questions help you look under the hood some more. That's what the taxpayers are paying us to do.
May I say there were great questions. So we really appreciate it, Dr. Walsh. Thank you.
Thank you.
I think I'll go ahead and jump in with a couple questions. Mine are mostly clarifying, and Tom's already asked some of them, so I should be relatively quick. I just wanted to make sure that I was understanding sort of the differences between the projections and calculations that you provided on slide 12 with the balance sheet, or the revenue and expense statement that you submitted, because they don't quite match. And I think it's because things are bucketed differently. So I just want to confirm that on your slide 12, you've included fixed payments in the other operating revenue. Is that right?
That's correct.
Okay. All right. The numbers still don't 100% line up, but they're that I think is the big variance. So thank you. That's super helpful.
It's because it's a run rate. It's an annualized version of
okay.
May. Yeah.
Got it. All right. Thank you. And thank you for following up on the additional detail related to the commercial rate in terms of if you had said, for example, 75% of your commercial volume came from out of state, I could understand why the 4.7 wouldn't have a big impact on Vermonters, but 25%, while large, still seems like 75% would impact Vermonters. So I think having more background on that would be super helpful. In terms of your partnership with the other hospitals in the collaborative, are you expecting savings at some point from that initiative? And if so, did you book any of those in 25, or when would you expect to see that?
Great question. I'll start with that, Laura. So I guess the first answer, Robin, is we better see savings from that collaborative. And yes, we do expect it. So right out of the gate, there's membership savings, substantial, close to $100,000 a year in membership savings. What is really planned is that there's substantial savings from a new group purchasing organization and arrangement as well. And what we're really looking to count on is direct substitution, not even asking any physician to change what they're utilizing, but saying this is the exact same item just from a different group purchasing organization, and here's what we can save. We did not budget that for fiscal year 25 because we actually just joined in the collaborative officially, I think in July. And so we have not budgeted that for fiscal year 25. I don't believe, Laura, but
No, we did not.
What we did budget is there are shared service arrangements that we have with the retreat already. We share IT staff between the two sites, and that is budgeted for fiscal year 25. What we hope from the collaborative is that we'll be able to actually have some fractional employees that will even be able to be shared amongst additional hospitals. But it's all still in the planning process. I hate to say at this point in time, the tangible is the membership dues. And then I believe what will come very rapidly after that is the savings of through the group purchasing organization without any change in what we're utilizing. And we're actually going to be reporting on that quarterly to our board because that's been a big part of this change with them as well, is wanting to keep an eye on this with us. I hope that answered your question, Robin. I don't know.
Yes, thank you. I was anticipating given the newness of your newness into the collaboration that it might take a while, but I just wasn't clear on what you had assumed. The other question I had was, and you may or may not be familiar with all of the materials, but in your submission, in your workbook submission, there is the commercial rate decompensation table. And I was a little bit confused about the numbers in that table don't seem to tie out to the balance sheet, which they do for other hospitals. So, and for example, it seems to indicate that the rate impact of the commercial rate increase is negative, which isn't really jiving with what your narrative says. So I don't know if you have any way to explain that, or if that's maybe a follow-up with our staff.
I think it would be best as a follow-up to this with the staff. I guess I'm not clear on how revenue, how are you tying it out to the balance sheet?
Well, the NPR does not match.
The P&L, yes.
Sorry, the P&L, I misspoke.
Okay.
But it does, like for example, I'm trying to follow projections, budget to budget, and then projections to budget, and the projections to budget don't match, for example. And we don't need to.
Definitely, yeah, I'll schedule some time with Alina and.
Yeah, and there might be some versioning we have to look at, but I know there's some discrepancies between the payer revenue and the income statement, so we'll need to connect anyway, Laura, but we'll do that.
Okay, great.
Robin,
I was confused, and so just wanted to see if we could clear that up at some point. Thank you.
I think I figured out that the workbook for them is still based in gross revenue as opposed to net revenue. That when I was struggling with this too, and I think that's where I figured it out, but I may be wrong.
It's not gross.
Well, it doesn't seem like it's necessarily, well, Dave, I leave it to you if you want to go down the rabbit hole now, but
that's fine. I think it's just, it's got weird, it's like got more bad debt than, anyways, I think it's just not right.
Great, thank you. I think that's all I had, and if I missed something, I'll pop back on. But I think that's it for me. Thank you.
I mean, I was looking at this and that's what I tried to figure out, but I'd love to have a cleaned up workbook that we can use.
Yeah, we can do that.
That makes more sense, but I'll just continue. I just had one more question, which was regarding the Wyndham Birthing Center. Is that the OB center within the hospital, or is this a freestanding birthing center?
Wyndham Birthing Center.
Sorry.
We have a birthing center in the hospital.
Okay,
and
I think
we have a Four Seasons OBGYN practice.
okay.
There are no freestanding birthing centers around us. Yes.
No.
Okay. All right. Thank you. That's the only question that I thought I picked up on maybe I misread the submission, but I thought I saw something in
Wyndham Aging, working with Wyndham Aging or anything. Maybe that, Dr. Merman. Don't know if that jumped out, or is that?
I don't think that
could
was
be my bad in my notes. So, but thank you.
You bet.
I just had a couple, I guess I'll call them little quick questions.
Go ahead.
Oh, sorry, Jess. On the narrative, you described $106,000 to the lobbyist group VAZ. Is that fairly steady every year, and what is that based on?
It is fairly steady every year. And it's based on our participation in the VAZ program as well as AHA. And it's just membership dues, essentially.
Based on your total revenue of the hospital?
Yes, there's a calculation.
And actually, as a follow-up to one of Robin's questions, we actually, through the collaborative, will get a discount to AHA membership, which is actually probably another $20,000 a year savings that we'll get in a discount from them for that through the collaborative.
And then the other part of this question asked about any marketing, advertising, or branding, but I didn't see any listed. Is that because there's none, or?
It's just sort of a negligible amount is how I would characterize that. It's not, just to give you a scope, we don't report it even on our 990. It's not, I would say it's insignificant.
And then Leapfrog, I haven't gone back and looked at it more recently, but it looked like a number of hospitals in Vermont don't participate in the survey. Why do you?
I would defer to Dr. McGraw on that one.
Yeah. So I'll say that Leapfrog is able to pull a lot of data from publicly reported sources. You can also engage in a more in-depth survey with them. We actually don't do the more in-depth survey. Our grades are based on the publicly reported data that they pull. I don't believe that they pull from critical access hospitals, so that limits who they're working with. So there's some, just programmatic limitations about who's included in that.
Right. Yeah, they have the larger hospitals. Okay, so why don't you do the more in-depth survey?
We've looked at it a number of different times, and we're not averse to doing so. But it is very involved, and it requires quite a bit of a commitment of staff time. And with limited staff, we're really focusing on where we get the most bang for our buck, as it were. And so really focusing on our quality patient safety initiatives that we've been doing rather than on the grading criteria that Leapfrog has seemed the most expedient way for quality improvement and patient safety improvement this far. I would not rule it out in the future. It's just not the path that we've taken as the priority at the moment.
And then the provider tax discussion, I thought was interesting. I have to admit that I'm not that well versed in the provider tax, so some of this is a little bit new, and I apologize if my questions show some of my ignorance on the topic. So you pay in 6.7 up to 7.2 million. You get back 670K going down to 630K. And the money goes to Medicaid, right?
So 640 in FY24 and 605 0.07 in FY25.
Oh, okay. All right.
So,
If
and
the-
Chair Foster, that is what we pay, is that
Yeah.
about 6.5, and then there's a federal match to that. So quite honestly, to the state, we're worth about 13 million or plus in terms of tax. And then where that goes, yes, it goes to Medicaid, but I believe it goes to other programs as well, because I think if you took the totality of all the provider tax with the federal match, it would probably be greater than the total cost of Medicaid in the state, but I'm not positive about that.
And I can ask my other state colleagues, but do you have any sense of what that money is used for? I assume it's a wide array of things.
And I'm sure it's very good things. I actually asked our legislative delegation about that as well, and they were not necessarily sure. They talked about their role, and I think from my perspective, I think that's a great thing from a collaborative work across the state, that to try and really look and see. Dr. Hamery, I think, had mentioned in his recommendations that he thought there was enough money to sort of fund the future of healthcare here, but it may need to be reallocated. And I think it would be wonderful to see in a very transparent way how things flow, because I'm sorry to say, I'm not sure how it all flows. And I didn't seem like our legislative delegation also really completely understood that. And I think taking that big picture would be a really important thing for the state in a very collaborative way.
And we just approved rates the other day, and help us if we're not spending enough on healthcare at this point.
Yes. Yes, indeed.
That's all I had. Thank you. I appreciate your presentation today.
Thanks, Chair Foster.
I think last but not least, for the end of a long day here is me. Thank you for the presentation. Thank you for all the hard work you're doing. On the quality front, there's some impressive accolades coming your way, deserved. A couple quick clarifying questions I've been asking all the hospitals, so I'm just trying to get a sense of the 4.7 commercial rate increase, how that's distributed across inpatient, outpatient, and professional. Is it equal, 4.7 across all, or is there some distribution other than that?
Well, it's mainly, there's a difference between professional and facility, obviously, but yeah, it's pretty much across the board on the facility.
Okay. And do you have an assumption in the budget for what the Medicare Advantage rate increase would be? Is it different than your Medicare assumption?
No.
Okay, so the assumption is 2.9, similar to your IPPS. Okay. In the narrative, there was a question about investment income, and the response was, we're not able to project investment income at this time. Does that assume that you've budgeted zero for investment income?
We don't budget for investment income.
Okay. And what investment income was earned in 23 and projected for 24?
We didn't project for 24.
Okay.
Might have to go and look at 23.
23, okay. That would be helpful. And is there anything about actuals today, for example, of any earns or gains or losses on investment would be helpful to just understand for 24 to date? Just trying to get a sense of.
I mean, it falls into our non-operating section of our P&L, which is, below the line. So we typically wouldn't be reporting it.
Okay. Well, anything that you can provide on past investment performance would be helpful to understand. There was a large projected 340B revenue for this year. If I'm looking at this, and if this is the most up-to-date version, it's about 4.7 million on 340B, which seems higher than certainly the budget and higher than what your for 24's budget and higher than what you're projecting for 25, which is only 1.7. I'm wondering if you could just speak to that bump up this year. I'm on the P&L. So I'm looking at the P&L and I'm looking at the line for 340B and I see 4.7 million projected for 24. And then I see it go down to 1.7 for 25. And it was 1.6 and sorry, it was
The P&L, where do you have that I submitted in the adaptive?
I'm in the workbook that I have. I can only tell you I have the workbook that was submitted.
I think we should just maybe again meet
Okay.
offline so that I can review it with you because that's not correct. It shouldn't be anything more than it was flat year on year.
Okay.
So there may be just a error, user error or something.
Okay, that's fine. It just seemed like it went up really high and coming down, and I just was wondering if there was some windfall that you were getting this year that was fantastic. Okay. And I guess my last question is, you described the need to recruit providers in podiatry and in cardiology to meet community need. Understandable given the aging of the population. I'm wondering though if you could speak to the strategic decision to hire additional, podiatrists, 2 additional podiatrists, 2 additional cardiologists, rather than increase the productivity of the existing providers. Looking at the work RVUs per clinical FTE, they're well below the 25th percentile for productivity. So I'm just wondering if you could speak to the need to hire additional providers rather than increasing productivity.
So actually, the worked RVUs that we have for these individuals at this point in time, the podiatrist that we've monitored is actually a very new podiatrist. So he's in the ramp up phase. His productivity is actually now to a point where he's actually getting incentives. So he's starting to get to the 75th percentile of his worked RVUs. The cardiologist was a transition. That had been somebody who had been working at Cheshire and has come over to us. He is actually now becoming incredibly swamped. That's a hard hire, the cardiologist. We have hired a second podiatrist. Starts in September, a few weeks. But the cardiologist is a need. Our cardiologist is ultimately going to retire at some point in time as well. So we need to be making sure we have somebody in place. We used to get 1.2 FTEs from Cheshire in Keene. And so we've also believed that with the growth in our community, we're ultimately going to need to have 2.0. But it's going to take a while to recruit another cardiologist to this community as well. So it's in the budget for the hope of getting the recruitment done. But the volume increases that Laura has budgeted are actually really within the cardiology program as it is today.
Okay, so maybe, I'm just looking at the clinical productivity submission. It looks like the year of the data was 23. So if there's updated clinical productivity data that suggests higher, relative to benchmarks, that would be really helpful for us to see.
Fantastic. Thanks. We can do
that. Thank you.
Yes. Thanks.
I think that is all I have.
Great, thank you. I'll turn to the healthcare advocate.
Good afternoon. Thank you. I'll be brief because I know it's been a long day. I just wanted to ask a clarification about on your income statement. It looks like you're budgeting $0 for ACO dues in 25 and $0 for insurance and $0 for marketing, which I know Ms. Bruno you talked about. Just wondering if you could elaborate on those decisions a little bit more.
Again, I don't know where you're seeing that. We're not budgeting $0 for ACO dues.
Okay. Well, I'm glad I clarified it. Okay, well, we can touch base on that another time. My other question was refers to your audited financials, and you talked a little bit about the long-term debt and the bonds that you have. It looks like a couple of them are variable interests, and you have these interest swap agreements. And I'm assuming that if you could have pursued fixed rate you would have done that, but I'm just wondering if you've considered, refinancing those in any way, or if that's not possible.
It wouldn't be possible at this point. We have spent the entirety of the 2019 bonds. We have a small amount remaining on the 2016, which we are planning on spending on the MRI replacement. And so there's no real option to refinance or anything like that.
Okay, that's what I figured. I just figured I would check. And then my last question was, in general, we've heard more about AI from you guys than any other hospital so far, at least in my view. And I've read some research that suggests that it'll reduce spending in healthcare by 5 to 10%. And I think we've seen similar estimates with EMR. So I'm wondering why you think AI will be different than EMR in terms of cost savings.
Well, I'll start that. Dr. McGraw, you might want to chime in. So I think there's actually a very profound projection for the future that, everybody's worried that AI is going to mean people are going to lose jobs. What you hear is whoever doesn't embrace AI is in a leadership role, they're going to lose their jobs because AI is going to actually have a profound impact. Healthcare always lags behind, but I believe, for what it's worth, that AI is different than EMR because the AI technology is really universal, whereas an EMR is only relevant to healthcare. So AI in other industries, so I mean, I don't know if anybody from the insurance industry is on, but they're using bots to actually manage their claim processing already. People are far ahead of hospitals and healthcare in the use of AI. And I think that it will have a very profound influence. And I can tell you as a patient, I have seen the impact. Came from California before I came to Vermont, and AI was already being used pretty rampantly in healthcare. And I saw the benefits as a patient: ease of access, ease of connecting with providers, ease of being able to communicate, ease of paying bills, a whole host of different things that was foundationally driven by artificial intelligence built into digital front doors and other things. This technology has a much more universal ramification than an EMR does. So that's my opinion, Sam, but I'll turn it to Dr. McGraw, who knows a lot more than I do.
So one thing I think is a good example of the impact it's going to have is our AI scribes. So right now, when you go to see a physician, for example, they sit and look at the computer and type in a whole lot of things while you're sitting there with them, and that's really unsatisfying for you as a patient. And frankly, it's not the physician's whole job of that visit. And in fact, they spend hours and hours of what we call pajama time, which is finishing the notes about that visit with you in the evening and getting those orders placed. And it's a huge physician dissatisfier, and in part required by our EMR and all of the boxes that need to be clicked and checked and ticked and tied. The thing about AI is it allows that visit to be in AI Scribe is it allows you to have a natural language visit where the physician or provider is not typing everything into the computer, but having a conversation with you. And at the conclusion of that conversation, there is that note with the appropriate components in there. And the physician then can quality check that and make sure that it's appropriate for what it said. That is a huge satisfier for clinicians to get their lives back and to not be spending all that pajama time. That's a big impact, even if we're not even looking at any kind of increased numbers of visits, although there may be some improvement in that. But there's a really big impact in terms of provider turnover, which is an extremely expensive part of healthcare, both for actual dollars and also access for patients. So that's just one example of the ways in which it's a benefit as opposed to the EMR, which has inadvertently created enormous impediments to our workflow process.
Well, thank you. Appreciate it. That's all I had.
Can I just jump back to Jessica's question about the 340B. So just to kind of close the loop on that one, in December of this year of December 23, so of the fiscal year 24, we received a recoupment from Medicare on our 340B program, where we were part of that group of hospitals that was under reimbursed with between 2018 and 2022. We got a 1.9 million recoupment from Medicare on the 340B program. So it's essentially money that they owed us that we were under reimbursed for within that 2018 to 2022 period. And so if I annualized part of 24, it might have overrepresented that number. Do you see what I'm saying?
Yes. Okay.
It
Yep.
inflated our 340B number, and then I annualized it. So
Okay.
for the projection. Yeah. So
Okay.
that's why there's seeming to be a large bump in our 340B reimbursement for 24, which will not continue in 25.
Okay, great. Thank you.
Okay, I think that's all we had for Brattleboro. Thank you everyone for coming. We have public comment that we take, and you're welcome to stick around for it, or to depart. And then we'll end the meeting. But thank you for your presentation and your submission to us.
Thank you.
Via the raise your hand function, if anyone has a public comment, let us know. All right, I'll have a quick trigger today because it has been a long day and I see none. So thank you everyone for attending. Is there any old or new business for the board? And I will move that we adjourn.
Second?
All in favor, say aye.
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 Aye. All right, thank you. And thank you very much, Michelle, for your work today and your help.
You're welcome. We are off the record.
Good afternoon.
Bye.